Our next section is bone and joint infections. There is probably, besides the PPD, no part of infectious disease more mistakes are made than the diagnosis of bone infections. And that is because you pay attention to what you see your own attendings and faculty do. If you don't know anything about osteomyelitis, this is going to be a very easy section. If you've got a lot of experience, you're going to be screwed up. Why? Because you're going to have to unlearn everything you ever learned. In bone infections, the question is always this. You have a diabetic person with peripheral arterial disease, and they've got an ulcer. Now, ulcers are by definition warm, red, tender, warm, red, tender, warm, red, tender, and swollen. They are warm, red, tender, and swollen. They are warm, they're red, they're tender, and they're swollen. Now the question is that infection just in the skin, or has it gone into the bone? Now the pediatrician can talk about what the pediatrician wants. That's hematogenous spread in children. So I want to be clear here. This is an adult doctor. I may be childish, but I'm not a pediatrician. So in adult infections, it's contiguous infection. Now the other thing that makes it also more complicated is that if it says something like a draining sinus tract, the most important thing is never culture that. Never culture the draining sinus tract. The culture of the draining sinus tract does not tell you what's inside the bone. The culture of the draining sinus tract does not tell you what's inside the bone. The culture of the draining sinus tract does not tell you what's inside the bone. The culture of the draining sinus tract does not tell you what's inside the bone, so don't do that. What test will you do first to see if it's inside the bone? A lot of you will say bone scan. Some will say MRI. But the first test to exclude osteomyelitis is always an X-ray. Do the X-ray first. Do the X-ray first to exclude infection inside the bone. If the bone X-ray shows osteomyelitis, what's the earliest finding of osteomyelitis on an X-ray is periosteal elevation. Destroyed new bone. Periosteal new bone formation. New bone formation, destroyed bone. Chips of bone taken out, sequestrum, involucrum. Periosteal new bone formation. First, get an X-ray. But I heard the X-ray takes 2 weeks to become abnormal. Yes, that's true. But I heard the X-ray lacks sensitivity. That's true, and so do I. However, the X-ray is still the first test. Would you skip over a chest X-ray, go straight to a chest CT? Would you skip over an EKG and go straight to the stress test? Would you skip over a chest X-ray and go straight to an angiogram? Would you skip over the engagement and go straight to marriage? No, I don't think so. So therefore, X-ray is first. If the X-ray is negative, that's when you get an MRI. Here's the other thing is, you ready? Bone scan. The only reason to get a bone scan is if you can't get an MRI. Don't get a bone scan unless you can't get an MRI. If you can't get an MRI, you don't have one. Can't get an MRI, I'm claustrophobic. Can't get an MRI, I got metal chips in my brain. Can't get an MRI, I'm walking in with bullets in my teeth. Bullet tooth Tony comes in. Can't do an MRI. Got metal in his teeth. Can't do an MRI, do a bone scan. Can't do an MRI, do a bone scan. But other than that, bone scan is nuclear medicine. Nuclear medicine. Here, isotopes. I suppose it could be this, and I suppose it could be that. Nuclear medicine. It's like the Shroud of Turin. I see. What do you want it to be, positive or negative? Bone scans, nuclear medicine. Talk to these guys, it's like Mr. Zelda on Bleecker Street. For another $20, Mr. Zelda can read your bone scan and your gallium too. I see infection in your future. MRI. X-ray first, X-ray negative, get an MRI. X-ray first, if the X-ray is positive, get a biopsy. You need to have that biopsy. You need to have that biopsy because if it is a sensitive Staph aureus, guess what the treatment is? Ox, clox, dicloxanaf, ox, clox, dicloxanaf. If it is, it's fun to play at the MRSA. Methicillin-resistant Staph aureus. methicillin-resistant Staph aureus. You would need vancomycin, or linezolid, or daptomycin. But did you know that diabetics, one of the #1 risk factors for osteomyelitis, have a 20 to 30% incidence of gram-negative bacilli? And did you know that if that has gram-negative bacilli, the treatment is ciprofloxacin and a fluoroquinolone? Why? Because ciprofloxacin goes into the bone. It concentrates in the bone. It's the only oral therapy for osteomyelitis. How do you follow the response to therapy? Sedimentation rate. Sedimentation rate. Should we stop at 4 weeks? Follow the ESR. Should we stop at 6 weeks? Follow the ESR. Should we go in and do debridement? Follow the ESR. How do you know when to stop, when to debride, when to start, when to continue? How do you know how far to go? You ready? 1, 2, 3. Follow the ESR. Follow the ESR. Follow the ESR. That's how you'll know. Follow the ESR. Now, staph, oxynaph, MRSA, vancomycin, gram-negatives, fluoroquinolones, culturing the bone, biopsy, most accurate, always. X-ray first, always. Culturing the draining sinus tract, never. Last issue here, joint infections. The joint infection, the first thing to do is tap the joint. Tap the joint. 0 to 2,000 cells is considered to be normal. If it's somewhere between 2,000 and 20,000, we consider that to be inflammatory. Gout, pseudo-gout, inflammatory. If it's above 50,000, we consider that to be an infection. If it's between these, you don't know. If it's between 20 and 50,000, you're uncertain. Except in the test, if they want you to know the answer, they have to tell you something. So if they want you to know it's infected, they'll tell you it's above 50,000. If they don't want you to know, they won't tell you it's above 50,000. Now, this tells you it's infected, not infected, inflammatory. If it is regular old joint infections, 40% staph, 30% streptococcus, 20% gram-negatives, then this will become very clear on the joint fluid culture. The real one that's hard to know is this: gonorrhea. Gonorrhea. The pharynx culture has about 10 to 20% sensitivity. The rectum culture has about 10 to 20% sensitivity. The urethra culture has about 20 to 30% sensitivity. The cervix has about 20 to 30% sensitivity. How do you know to go culture up and down and all around? What will make you do that? And the answer is, if you see polyarticular disease, a petechial rash, or a tenosynovitis, these 3 things will tell you it's time to culture up and down and all around. Joint infections. Joint infections. How do I know that it's staph and strep and gram-negatives? Tap the joint. Above 50,000, it's an infection. Under 2,000, it's normal. Between 20 and 50,000 cells, you're not sure. Staph and strep and gram-negatives. The culture have a 90% sensitivity. Very good, you're done. What about gonorrhea? The joint fluid culture, the joint is only going to be positive in 50%. How do I know it's disseminated gonorrhea? You culture up and down and all around. How do I know to culture up and down and all around? It's polyarticular. Tenosynovitis, it hurts when I move my hands and fingers. And a petechial rash. And that is how you will know to go do all this. You think I want to do all those things? Pharynx, rectum, urethra, cervix? Nobody wants to do all those. But it's the only way to catch the gonorrhea. Gonorrhea is a very picky eater. Doesn't grow up positive that much. Joint fluid, this is the only thing where to find a joint infection, you culture up and down and all around. What will tell you to get this? These things. Polyarticular migratory, tenosynovitis, and a petechial rash. Now,
What is different and what's unique about gonococcal infections when they become disseminated? Now, although it's true that terminal complement deficiency, C5 through C9 deficiency, predisposes to a Neisseria infection, most patients who get disseminated gonorrhea, it's not clear why they get it. We have to say here again that if you look at the normal values, we know that between 0 and about 2,000 cells, this is normal. Between 2,000 and about 20,000 cells, this is patients who have probably some form of inflammation, gout, pseudo-gout, rheumatoid arthritis. However, it's possible to have inflammatory disorders even going up to about 50,000 cells. Here, you're entering the hot zone. An infection is here above 50,000 cells. But the problem is that in between 20 and 50,000 cells, you cannot tell what it is. So that means if your question wants you to know that it's an infectious septic arthritis, they will tell you 60, 70, 80,000 cells, clearly above 50,000. If they don't want you to know that it's clearly infectious, they will tell you it's 5 or 10,000 or less. If they don't want you to know, and they want to say, listen, it's time to look at a gram stain and a culture. The gram stain will be positive in 60 to 70%. The culture positive in 90%. However, that's for staph and strep and gram negatives. Now, who gets septic arthritis? Well, septic arthritis, the more abnormal the joint, the more likely you are to have septic arthritis. A normal joint is less likely than someone who has osteoarthritis. Rheumatoid arthritis is more likely than osteoarthritis because it's a more destroyed joint. And the most likely to have a septic joint is a person who has an artificial joint. An artificial joint is the most likely thing to cause or have infection, predisposed to infection, because the artificial joint is the most abnormal of the joint surfaces. Now, for disseminated gonorrhea, there's two issues. One is what tests to get. The other is what would make you say to get those tests. This is how you'll know to go culture up and down and all around. And this is a very strange and unique fact. The fact that the joint fluid culture only becomes positive in 50% of people with disseminated gonorrhea. Don't you find that strange that it's a joint infection, but the joint itself is only positive in 50 to 70%, 50% or less? Strange. But that's the way it is. Let's look at some of our slides now. Okay, let's look at some of these pictures now. Our first picture and image is basically say, well, remember that we said the biggest thing about osteomyelitis is whether is it an infection of the soft tissue and the skin, or has it spread inside the bone? Here is a soft tissue infection. It could be from trauma, but most of the time now it's an older patient with diabetes and vascular disease. Diabetes gives you bad neutrophils. Vascular disease gives you bad circulation. Has it spread into the bone? What is the first test? What is the best initial test? What would you do first to establish a diagnosis? And remember, get an X-ray. An X-ray may lack sensitivity. An X-ray may need 1 to 2 weeks to become abnormal. An X-ray may need to lose 70% of the calcium before it becomes abnormal, but it's still the best initial test. The X-ray is positive for osteomyelitis. What would you do next? The answer is a bone biopsy. And do not swab superficial wounds. They don't correlate to what's inside the bone. Next, septic arthritis, a joint that is warm, red, swollen, and immobile. How can you tell this is gonococcus? You can't. You can't until you get a tap of that joint. Gas gangrene. Here's the one disease that we haven't done yet in this section. Gas gangrene. Prior to the Second World War, the most common cause of death in all warfare prior to 1942 was infection. More troops died, more Americans died in the First World War of Spanish flu, of influenza, than died from bullets. More Americans died in the Civil War from cholera, from plague, from various forms of infectious disease than actually died of bullets and bombs. So it wasn't until the Second World War. It is true that Napoleon lost more troops to disease at Waterloo than he did to British bullets. So in fact, most battles have been decided, in fact, by disease, not in fact by bullets and bombs. So this disease of gas gangrene was, prior to 1940s, was most commonly caused by warfare, shrapnel, dirt getting implanted. Let's look at this image. It means that you have gas-forming organisms implanted under the skin. A single spore can be implanted, and by gas gangrene, a spore germinates and Clostridium perfringens makes gas-forming organisms inside the skin. However, since the 1940s, the most common cause of gas gangrene has been replaced by warfare and been replaced with the automobile. So more Americans die of automobile-related gas gangrene than any other cause. It could be as much as a single spore planted under the skin, like going into your garden and putting one single spore under the skin. Gas gangrene is a surgical disease. Trauma and surgery cause it. Surgery is how you make the definitive diagnosis as you open it up. Surgical debridement is how you treat it, although giving penicillin is good too. But penicillin and antibiotics to treat the Clostridium without surgical debridement will not work. Surgical debridement without antibiotics will work. What's the best thing? Surgical debridement and antibiotics. Trauma, infection, spores under the skin, they germinate in the anaerobic environment under the skin, and then they make gas through your skin, and you need to be debrided. That's it for the bone and joint section.